We're going to let everybody kind of enter the meeting. Thank you, everyone who is joining us today for our statewide call. Today's topic is breastfeeding in the setting of substance use and recovery in Vermont, kind of an analysis of where we are now and what's coming next. And we'll give just another minute for people to roll into the room, and I will turn it over to Dr. Molly Rideout, who's faculty here at the VCHIP PQC Icons team, to get us started.
Thanks, Michelle, and thanks to everybody for coming. So for the next slide, we'll show these are all of our collaborators for this webinar. And the next slide will show all of our presenters. And we're each gonna introduce ourselves after our respective sections. But we have a lot of speakers from all over Vermont, which is amazing. So some from Burlington, from the hospital here, from Wick, from Newport, and from Southern Vermont. And thanks so much to all of you speakers for sharing your important perspectives and insights. And for the next slide, so just for some logistics, feel free to use the chat box anytime throughout the presentation if you have questions or comments. We will have time at the end for a discussion Q&A section, but along the way is fine too. And then if you want captioning, you can find it as instructed on the slide. And then if you want to ask a question out loud, of course, don't forget to unmute. And then please, please, please fill out the evaluation at the end. It's super helpful for us to know what we could do better, what we could do differently, what was great, that's kind of things. And next slide, none of us have anything to disclose, unfortunately. Next, and then so this is a roadmap of our session for today. So we're going to start in the inpatient setting at UVMMC in Burlington, and I'll talk first about a guideline that we developed for breastfeeding and substance use that we have developed 1 to 2 years ago. Courtney will then share her experience as IBCLC up on Baird 7 in terms of how it's been implemented and how it's been working clinically. Then we'll move on to WIC, where Jillian and Tricia are going to share some data about breastfeeding in Vermont and also talk about the WIC peer counseling program. Then we're going to move up to Newport, and Chantal will share her experience as an IBCLC working with families affected by substance use, and Brittany with her experience as a WIC peer counselor. And then we'll move down to Southern Vermont, where Kimberly will share her experiences as an IBCLC working with the population and specifically talk about the baby cafe that has been developed down there. And then Michelle will wrap it up with some resources developed by our team that are available on our website. So next slide. So with that, my introduction, I'm Molly Rideout. I'm a pediatrician. I spend a lot of my time working as a newborn hospitalist here at UVMMC in Burlington. I also run a pediatric clinic at the Lund Family Center residential program. And I'm a member of the VCHIP PQC team for improving the care of substance-exposed newborns. Next slide. So why is this important? We do have a bit of data. It's difficult to get substance data for opioid-exposed infants across the whole state and also across the whole country. There have been a couple of studies in different places. We do have UVMMC data for opioid-exposed newborns at UVMMC for any breastfeeding. So we took that data and compared it with all of Vermont data for breastfeeding for all infants, which is CDC data from PRAMS, which we got the 2023 data just last week. So there is definitely, there's about 95% of newborns across the state of Vermont have any breastfeeding at any time, starting off. And then for the opioid-exposed newborns at UVMMC, it's quite a bit lower, around 80%. And moving out to 3 to 6 months, these are all shifted way down, about 70 to 75% at 3 to 6 months for all newborns across Vermont. There isn't data that far out for all opioid exposed newborns in Vermont or hospital data, but a couple of isolated studies across the country, it's much, much lower in proportion for 3 to 6 months out. So this is important. Next slide. So in 2023, the Academy of Breastfeeding Medicine came out with a new revised protocol. And for this protocol, the reason for this was prior to this, there was kind of an absolute contraindication to breastfeeding for any woman or mother or birth parent who used non-prescribed substances. She was not allowed to do any breastfeeding. And people kind of realized this probably was a missed opportunity, that a lot of women or birth parents who might not use again, and we know what a benefit breastfeeding is. So was there a way to possibly make kind of individualized decisions about this? And they came out with this new guideline, which is basically recommending breastfeeding for birth parents who decide and say they're going to stop using non-prescribed substances by the time of delivery. So, and for a birth parent who's had recent use or a positive urine drug screen, the protocol recommends to support mothers or birth parents in establishing their milk production through pumping, and then to discard the milk for a certain amount of time until the substance has cleared. And then patients and parents and providers will use kind of a multidisciplinary approach for when the time is right for the baby to receive the breast milk again. And it also includes for lactating parents beyond the perinatal period, if there is substance use, that same approach should happen. Pump, keep milk supply going, but discard the milk until there's no more substance in the breast milk. And then next slide. So we at UVMMC, and as part of this ICONS team, developed a guideline, which is available on our website, that's modeled after the Academy of Breastfeeding Medicine protocol. And it includes encouraging breastfeeding for the first hour after birth for all families if desired. The thought was that there's really minimal transfer of colostrum during that initial hour, and the potential benefits outweigh any potential risk. And then following this initial time, just having an individualized approach, recommending establishing pumping to establish supply and discarding milk as long as needed, depending on the substance, if there's a positive urine drug screen or recent disclosed use. Lactation consultants are recommended for all of the dyads. And then another important part is just discussing breastfeeding and substance use with all families, not only the families that we know have been affected by substance use, and providing a universal handout that we developed that talks about different substances and the time that the substance is in the milk so that families can kind of use it even after discharge and know when there's substance in their milk that should not be given to the babies. And next slide. This is an example of our reference table that we looked into the pharmacokinetics of different substances and made this chart out of it, outlining kind of the time to elimination of the different substances and then recommendations of timing of when to reinitiate breastfeeding. And then it's just going to be continually updated with new substances as they pop up. And next slide. This is an example of our one-page patient handout with basically all the same kind of information, and again, given to all families, acknowledging that substance use may happen to anybody at any time, and just providing the full information. And next slide, we adapted this patient handout into plain language for all families. It's also available on the website. And we also translated it into, we didn't personally do that, but it was translated into 17 different languages. So then also that's available on the website. And there's another page on the next slide, which kind of shows what's inside and what it looks like. And so that is the gist of our work in this area. And Next up, Courtney is going to talk a little bit about how it's been implemented and, different successes and challenges along the way. Thanks, Courtney.
Hi, everyone. I'm Courtney Walker-Bork. I'm a nurse and lactation consultant at the hospital, primarily on the postpartum and newborn nursery unit. But our lactation team does work with anyone that needs us. You can move to the next slide. Thank you. So just general about our lactation program. We moved to a proactive lactation model in the last couple of years. So we try to see every family that is on our unit. After these new guidelines came into place, it definitely increased the amount of communication between lactation and the patients. With the trifold that Molly was just showing, it's included in every discharge folder. So when the lactation consultant is checking in with the family, we're watching a feed, if we're trying to wrap up the visit and talk about follow-up and what they can look for after, we all go through the handouts that are in the discharge folder. So bringing that out, looking at the different options and of resources for home. And then the trifold is really helpful. It is an opportunity for a conversation. Might not want to bring up any substances they use. And I've had a few families that this has sparked a conversation because it seems more of a safe space with this trifold and everybody's discharge folder. This has translated to our staff feeling more comfortable talking about substance use and lactation. It's not seen as something we need to not talk about around the patient. It's definitely opened up communication with the care team and communication between units. We share patients often. The NICU might have the baby for a few days, and then the birth parent will be on our unit. Obviously, if there's express breast milk, it's going to the baby, so it makes sense to have increased communication between the units. And next slide, please. Thank you. Just a recent case that came up. This was a 25-year-old patient, fourth baby, here with a repeat C-section. She was engaged through MAT through the community. Her baby was born term, well, on the Eat, Sleep, Consult protocol, which does have automatic lactation consult order from the provider in the order set. But like I said, we try to see every family anyway. Her urine drug screen was positive for cocaine on admission. Lactation had not seen the patient for the first delivery day or postpartum day 1. It was written that the patient had declined on the assignment sheet, so we kind of would just check in with the nurse and kind of skip over the patient. On postpartum day 2, the nurse asked lactation to see the family for a concern for breast pain and maybe wanting to talk about medication to dry her milk up. When lactation went in the room, the patient actually verbalized that her milk was coming in and she was interested in pumping. There was unfortunately, no equipment in the room to help the patient pump at this time. So lactation person went to go get this. This was myself, actually. By the time I came back, the patient was with social work for a long time. And in the end, several hours later, the nurse told me that the patient actually didn't want to pump. So I felt like this was a missed opportunity to support the patient in that moment of her decision to pump and see where things would go. So in general, early lactation involvement, if we had chatted about it on delivery day, the lactation person hearing the patient's decisions and hopes for feeding, I think that would have been really helpful for this patient. And then Molly brought up a recent case from on our unit. A similar patient had a positive urine drug screen for cocaine. She was supported to pump and dump until that was cleared. On discharge, she was pumping and giving express breast milk. The patient and care team were able to have open conversations about substance use and what to do if there was use after discharge for the safety of the baby and the milk. This baby was readmitted with growth faltering related to low intake. The baby was taking more formula discharged, but still some breast milk, which we obviously know is beneficial. This family was fully engaged in the system in a large part because she was able to make feeding decisions on her own terms, which we always want to respect the family's feeding choices. So as much as we can talk about that, the better. I think there's something on the next slide, Anthony. Thank you. Continuing challenges. When the baby's in the NICU, we definitely have been on increased communication between the safety of express breast milk. If the parent has been pumping and dumping, we always want to talk about when is it safe for use and how to indicate that to the nurse that will be giving the milk to the baby. And one of the questions that keeps coming up occasionally is repeat urine drug screen indicated for premature newborns. Molly and I have been chatting about this also. And then what to do if the newborn goes into foster care and the birth parent's urine drug screen is positive for cocaine. Definitely there's an opportunity for building awareness with the safety and substance use and the timing of when milk is safe. If I missed anything else, really chatting.
Hello, welcome, and thank you for inviting us to share information from WIC. I am Tricia Cassie. I'm the State Breastfeeding Coordinator from WIC, and I work very closely with Jillian. We are both IBCLCs. I'll let her introduce herself in a minute, but we are the ones that promote and support lactation in all of WIC. We train our staff and peer counselors, and I'll turn it over to Jillian for her to do an introduction quickly.
Hi, everybody. I recognize a lot of familiar names out there, but for those of you that don't know me, I'm Jillian McKinnon. I too am a IBCLC and a registered dietitian and work very closely with Tricia, as she noted, providing support to offices throughout the state, our 12 district offices, and look forward to sharing some information about WIC with you all.
So I will start off with how important WIC is in supporting parents with substance use and also parents in recovery. That road to recovery is often really hard and challenges, and there are lots of bumps along the way. So support is a really key factor in parents' success. And next slide, please. So here is a chart that shows Vermont's breastfeeding rates, and this is in WIC data, and we are higher than the national average. WIC collaborates and engages with lactation support staff in hospitals and healthcare provider offices, and with home visiting lactation counselors, international board certified lactation consultants, and so we can provide that wraparound care for our families in this state. So this table shows the breastfeeding rates for infants enrolled in the Vermont WIC program who have initiated breastfeeding. The state average of ever breastfed infants enrolled in WIC is 81%, and data from USDA Food and Nutrition Service shows that Vermont WIC has higher breastfeeding rates than most of the states and tribal organizations and territories. Next slide. While many breastfeeding dyads enrolled in Vermont WIC program initiate breastfeeding, state averages also show that there are 64% exclusively breastfeeding at 1 week, and the rates of exclusive breastfeeding drop off to 56% at 3 months, 52% at 6 months. This dramatic drop-off of exclusive breastfeeding rates at 1 week indicate that increasing maternity care practices that support breastfeeding in the hospital and including follow-up lactation visits during those first weeks at home could really help improve the rates of exclusive breastfeeding. WIC participants that have the support of a peer counselor receive support and encouragement at key times during pregnancy and also after the baby arrives, and this helps parents meet their infant feeding goals. Next slide, please. The WIC Breastfeeding Peer Counselor Program was introduced to the Rutland District Office in 2005. During the following 7 years, we expanded the program to Middlebury, St. Albans, Bennington, and then Burlington. Peer counselors are current or past WIC participants, and they have breastfed for at least 6 months and preferably have been breastfeeding for at least a year. And they have been trained in how to support and offer that general lactation support and guidance, information, and encouragement to parents enrolled in our WIC program. Next slide. Peer counselors are now available in every WIC district office. We expanded that program in 2001. WIC participants are given the option to receive support from a peer counselor during pregnancy, and if they agree, they will connect with the same peer counselor over the course of their pregnancy and postpartum period. If they decline to have that peer counselor support during pregnancy, they are later offered the support of a peer counselor after the baby is born, especially if there are any lactation challenges. We see that breastfeeding rates for individuals which accept a peer counselor's support are generally higher. And now I'm going to pass it over to Jillian.
Thanks, Tricia. So WIC staff and peer counselors are trained using the WIC breastfeeding curriculum, which is provided to us by USDA Food and Nutrition Service. This training is divided into 4 levels, so staff are trained based on their role and scope of practice. Peer counselors are trained to provide basic breastfeeding support through their levels 1 and 2, and they yield to a breastfeeding designee in their WIC office. This is, they yield when WIC participants are experiencing problems that are sort of outside of their scope of practice. So WIC breastfeeding designees attend the full training, so all 4 levels, and can really help to problem solve those more complex breastfeeding challenges that may arise. This is where challenges with substance use may come up, and they can provide some additional support. So the training is provided virtually by a regional training team of nutritionists and breastfeeding coordinators from the state WIC agencies, Connecticut, Maine, New Hampshire, and also here in Vermont. We offer this training annually with levels 1 through 4 presented in the spring and levels 1 and 2 presented again in the fall. We do welcome community partners such as yourselves to attend, so you can reach out to Tricia and or I, and we can connect you with more information about that. Next slide. So before we pass this on to Chantel and Brittany to share how they work together to support WIC participants and to also share a recent case involving a parent who experienced substance use, we wanted to end with 2 quotes from participants that were sent to their peer counselor. So here saying, "Thank you for your help. Without your assistance, I wouldn't make it through. You are so amazing." Next slide. And here on this slide, you can see this text highlights the anticipatory guidance offered by peer counselors saying, "Thank you so much. I swear every time something changes, you're on point messaging me the day or day after it starts with these wonderful reminders and tips." So now we'll turn it over to Chantel Nadeau, who's a nutritionist and breastfeeding designee in IBCLC with the Newport office, and Brittany Lasco, one of our Newport breastfeeding peer counselors.
Good afternoon. My name is Chantel Nadeau. I'm a public health nutritionist and an IBCLC in the Newport District Office. And I'm also the WIC designated breastfeeding expert for Newport, St. Johnsbury, and St. Albans. I support WIC staff and peer counselors with any challenges they may have in supporting families with breastfeeding. And I'm also a WIC certifier providing WIC services to moms and families. I supervise the peer counselors in Newport and St. Johnsbury, and one of those is Brittany. As Tricia and Jillian have mentioned, WIC has a unique opportunity to support families to meet their feeding goals and also to support them through some challenges. Brittany Lasco is one of our peers who is going to talk about a recent case that she had supporting a family. Go ahead, Brittany, I'll let you introduce yourself.
Hi, everyone. So my name is Brittany Lasco. I am the breastfeeding peer counselor for the Newport and St. Johnsbury district. I support moms and I help them reach their breastfeeding goals by letting them know what to expect. I teach them a little bit about breastfeeding. I answer questions that they might have and I help them overcome challenges. So a recent case that I had, I got this mom on my caseload when she was 25 weeks pregnant. This was mom's second baby, and she was really determined to breastfeed. Before she was even placed on my caseload, Chantel made me aware that mom had a history of substance use and she was going to Savita for treatment. But Chantel said that she didn't see a reason why mom couldn't breastfeed. So throughout pregnancy, I just supported this mom like I do all my other clients. I invited her to a breastfeeding class. And again, like I let her know what to expect. I taught her some about breastfeeding. I answered questions that she had. During pregnancy, she did respond to a lot of my messages. It was more just small talk on how she was feeling and talking about like how excited she was to meet the baby. We talked about limiting visitors after the baby was born because for her first baby, she was really overwhelmed because so many people were in the room. So for this next baby, she was talking about how she just wanted it to be her and her spouse. So after baby was born, mom and baby were both doing really well. Mom shared that she was pumping and dumping. She didn't disclose anything to me, but Chantel emailed me. She always kept me in the loop, so I knew how best to support this mom. She said that mom had to pump and dump until she was cleared by the doctor. So so after baby was born, I just helped mom with pumping tips and ways to bring in her milk supply. She was pumping often at first, and which I thought was really great. And then throughout the weeks, mom's pumping started to slow down and she reached out to me and she said, my milk supply is really low. Can you help me? So I shared some tips to help her pumping, to help her supply increase. And then also for this mom, I would say when it comes to support, I just like reached out to her more frequently than I do a lot of my other clients just to see like how she was doing, how baby's doing. I was also really careful about what I said to this mom because I wanted to be really sensitive to her situation. So after a few weeks of helping this mom with her supply, she no longer responded to my messages. I think baby was a month, Chantel reached out to me and said that mom was cleared by the doctor and she was able to give baby her breast milk, which I thought was really amazing. Yeah, I'm not sure if she did end up giving baby her breast milk, but I think we stopped talking around the 2 to 3 week mark. So, and she was still pumping, so I'm assuming she did. So I continued to reach out to mom until baby was 6 months old, and then that's when I discharged her from my caseload because she was no longer breastfeeding.
Thank you, Brittany. I love this story because I think it really highlights a couple things that we do here at WIC. One is that we really try to build a trusting relationship with our families and our clients so that we can meet their goals. And also it really recognized that sometimes the feeding plan is not always what they intend. And in WIC, we're in a different support role. So we're not making the decisions about whether it's a safe situation where mom can provide the milk or not. We're coming at it that every woman has the right to breastfeed and provide her milk for her baby. And we want to support them and give them the tools that they need to navigate through the process. So making sure they have a pump on discharge, working closely with the hospital here to make sure that if the pump is through Medicaid, that it's been provided, if there's a gap that WIC could help with a pump, making sure that our peer counselors have enough information to be able to support the family with situational awareness, but also being respectful of the family's privacy as they're sometimes navigating a challenging situation that might be involving DCF or other agencies. And so I just think it's a real it's a real blessing in WIC to be able to work with these families, and care coordination is crucial. Working as a collaborative team is important, and I'm grateful that in our district, WIC has a seat at that table and that we have people like Brittany to support our families. Thank you.
Hi, everyone. My name is Kimberly Weiss-Lewitt. I am an IBCLC lactation consultant, and I also am a perinatal mental health therapist practicing in Southern Vermont, both in private practice and at Southwestern Vermont Medical Center. Can do the next slide. I wanted to highlight today something that I think we've been touching on throughout the presentation, but it is the comorbidity of substance use and mental health challenges. So we know that oftentimes when people are using substances, it's coming from a history of trauma and mental illness. But we also know, and new research is really showing that perinatal or lifetime use of substance use is also going to increase the risk of PMADs and perinatal mental health challenges in the postpartum period. And we also know, this is a hot topic in lactation, about lactation and mental health. I think social media would have us believe that if no one breastfed and everyone weaned, that everyone's mental health would be perfect in the postpartum period. And we all know that that is not at all true. And the research really supports that successful supported breastfeeding, the kind of breastfeeding and lactation journeys that we've been talking about in this webinar, are very protective of mental health. There was a recent systematic analysis that showed that by and large, when people felt supported in their breastfeeding and lactation goals, it built self-efficacy, maternal identity, fostered bonding, calmness, well-being. But we also know that lactation and the feeding journey really has this potential for healing, but we also know it has the potential to create even a secondary trauma, feeding trauma, when goals are not met. And the research also showed that when people's feeding goals weren't met or they were experiencing difficulties, that this exacerbated distress and guilt and the potential for depression. And we think especially about the vulnerable population that we're talking about today. We never want to be in a situation where people have feeding goals and they're not getting the kind of support that we all know that they need and deserve. And this key to support is really a balance of everything we're talking about. It's this professional support, this non-judgmental professional support, but it's also this peer support that Brittany just touched on so beautifully, as well as partner and family involvement and encouragement. Something we've known for a long time is that one of the best indicators of breastfeeding success is to have a partner or a close support person who is supportive of the journey. Go to the next slide. So here in Southern Vermont, we have instituted the first baby cafe in Vermont, actually the first baby cafe in Vermont, New Hampshire, or Maine. It is being supported by Southwestern Vermont Medical Center, and it has been wildly successful. And Baby Cafe is a community of new parents, both birthing parents, mothers, and their partners, and extended family. It's free. That's really important. And it's a drop-in model. So if anyone here has ever been to a new parent group that was sort of where you sat around in a circle and introduced yourself and talked about one good thing that happened this week and one thing that was hard this week, I think those groups have a lot of value. But Baby Cafe is a little bit different. It's much more casual. It's much more relaxed. People come late. People leave early. And I think especially for families that are navigating mental health challenges and or substance use disorder, the casualness of the space really allows them to feel welcome. No one's put on the spot, if you will. Baby Cafe is a national organization, and there are some requirements that have really helped, I think, support our cafe. And one is that IBCLCs are present. So we have 3 IBCLCs. There's 2 of us always there. And if you were to think about starting one in your community and didn't have an IBCLC available, there are some pathways to have other trained lactation professionals there with IBCLC support. It's a cafe, so refreshments are provided. And I'll talk a little bit about the partnership that we have with Bennington Community Market. There's an infant scale at every group. Infant scale at every group has actually really been incredibly helpful for our community, because a lot of times feeding challenges and weight concerns is really one of the main reasons that people start supplementing with formula and eventually give up on exclusive breastfeeding, which is why one of the reasons I think we really start to see that decline as time goes on. And we've had families that have really benefited from being able to do a regular weight check-in with professional guidance. And because we're a small community and we work closely with the main pediatric office, which is also with SVMC, we've been able to, with parental agreement, really communicate weights back and forth and help adjust feeding plans as families have gone on in their journeys. So people that may have given up on exclusive breastfeeding in the early weeks or months have continued to exclusively breastfeed and meet their goals with that support. Partners are enthusiastically encouraged to attend, and that has been a huge benefit to not only the families and but also the community, just feeling like this is a welcome space. And also, we link to other community supports. And Baby Cafe asks us to link. We kind of go beyond linking and invite people basically to the table. If you could go on to the next slide. Beautiful. So our numbers speak for themselves. Our Baby Cafe attendance in 2025 has been phenomenal. We often have, on average, 20 families that come every week. And like I mentioned, it's not just the IBCLCs that are there, but it's also community members that are involved with family support show up. They share a meal together. So we have WIC regularly showing up, the Sunrise Family Resource Center, which is a really important support, especially for folks struggling with substance use disorder. They come regularly, and we have a couple Sunrise workers who regularly just bring people from their caseload with them, and we all spend time together, again, share a meal, talk about infant feeding, mental health, all the things. We have our VNA visiting nurses come regularly to connect with families there, and Bennington Community Market is a nonprofit community market, and so we've partnered with them, and we have, a beautiful meal actually every Wednesday, a nice lunch that families are able to enjoy together. I've had some clients tell me that this is their date day, like the partners come together with their babies and share a meal and get to know other families. We've also interfaced with the Blueprint RNs and mental health workers in our community. So I feel I'm on a bit of a campaign right now to see if we can grow some baby cafes in the state, because I really feel that the baby cafe model that we've been working with over the last 2 years is this possibility to do a lot of good in essentially a small amount of time, and to touch a lot of folks and bring together community organizations at a designated time every week. Thank you.
Okay, well, thanks everyone. I love how everybody brings such a great perspective from all other areas of the state. So we aren't just focused right here in our little area in Chittenden County. So my job today, so I am also a pediatrician, outpatient. I also collaborate with many people as the Vermont AAP state breastfeeding champion. And here I've been working with VCHIP on the ICONS team since 2017. So what I just wanted to do was we have a new website here at the PUC, and I just wanted to bring up some of our resources and also just review the other resources around the state, kind of put them all and collate them in one area so we could easily access them. Next slide, please. All right, so here's the new Improving Care of Newborns with Substance Exposure website. And just wanted to orient everyone that, there's been a lot of upgrades and updates on all of the Larner College of Medicine as well as the PQC websites. So you'll find on each of my slides a link to the webpage that I'm highlighting. Next slide, please. So from the main site, there's a way to navigate to resources, which takes you to resources for all of the different VCHEP projects. And if you go under the perinatal health tab, you will see there are different things from educational offerings like today, but also you have materials for both families and for healthcare providers. So what you can see here on the right of the screen are the perinatal substance use disorder resources, some of them that we've already highlighted here today, some that we didn't talk about yet here today, including, a cannabis use and breastfeeding info flyer we put out a few years ago, some of the neonatal abstinence syndrome work from the UVM, now Golisano Children's Hospital, as we've rebranded recently, and then some guidelines along toxicology testing that are in use here at UVM Health. Next slide. So this also just brings up, so just people can see the sample hospital guideline is here. Please feel free to edit this. We did put an overview saying this was a sample guideline and we developed it in 2024. But please feel free to use this information to develop your own local guidelines or protocols for, how to navigate the in-hospital guidance for pregnant individuals and postpartum people who have used substances recently. And again, the link to on the bottom of the slide will bring you right to this resource. Next slide, please. And this was already shared by Molly, but one that I've been asked to share before. So again, this is the one pager. Really, it's a quick I would call this the quick reference guide that you certainly could have and just quick check. The last time I used cannabis was this. How fast will it clear from my breast milk? And how can I help support a postpartum or breast or chest feeding individual as they are navigating substance use. So next slide, please. There's also family resources here. It's again on that same perinatal health resource page. And in this case, this is where you can find a couple of videos. So a substance use in pregnancy video we initially developed for children with opioid exposure at the Golisano Children's Hospital or the UVM Children's Hospital until a couple weeks ago. And then we were fortunate to have our partner, who I think I saw on here today, I think Kayla was here, then make a video that's a little bit more statewide. So the first one you'll see is substance use in pregnancy, which is for delivery anywhere else in the state other than at the Children's Hospital. And then we had a Children's Hospital specific video. And then that breastfeeding and substance use guidance, those are the family handouts, which we'll look at on the next slide. But these are the ones that are translated into 16 different languages. So next slide, please. And here's again what it looks like in English. And so it's just really wonderful to have these in 16 different languages so that we can share these with all families, regardless of what their primary written or spoken language is. And these were reviewed and had gone through quite a process to get them to an appropriate reading level and to be sure that they were non-triggering and were reviewed by our patient and family advisory panel. Next slide, please. And then many of you are familiar of all the other statewide resources. And again, just the reminder that there are just so many different resources. It's nice that we can kind of link back to one area to get what we need. So next slide. And then One More Conversation is also a campaign that our team helped provide some feedback to. And again, this has both patient education materials and provider toolkit materials. And so kind of trying to bring the language all to be in alignment is always beautiful, as far as I'm concerned, to have the same language and recommendations in patient educational materials and provider toolkits. Next slide, please. And then I've been so happy and impressed to see that VDH has really done a beautiful job on their website to really make this just a wonderful resource of information for anyone in the state. And I actually really love the knowledge plus support plus confidence equals success. And I think that's true in many realms, but especially true here in breastfeeding. And just had some really wonderful resources here on the VDH website. Next slide. And then, of course, I know we've talked about this a lot, but just wanted to drop in the link to the WIC breastfeeding landing page, and had some great information about peer counseling as well as overall breastfeeding supports and how to access those. So again, wanted to put all of these wonderful resources under one PowerPoint. Next slide, please. And then I see a lot of questions, so I would recommend, like, I wonder if we could put the slides down and kind of open it up for a discussion, or we could certainly share the questions that have come up in the chat.
Yes, so thanks, Michelle. That was fantastic. And thanks to all the presenters. It would be so great if all the presenters could pull up their cameras if possible. And then for any participants, it would be great if you all are in a place that you can share as well. It's always nice to have discussion when you can see people's faces, but also understand that, you're eating lunch, whatever, don't want to watch people watching you chew. I don't know, whatever the reason. So would love to hear questions that people have. There's been some typed into the chat. Maybe we could start off and have Kimberly, maybe, I know that you've answered a lot of them, but if you want to just maybe give a verbal kind of summary of some of it, that would be great. And then other people be thinking of other questions that you have.
Yeah, absolutely. My amazing colleague Bridget Bremersky is in the chat, like getting my back, like answering things, which is so wonderful. So she's on today. She is a pediatric provider in IBCLC who's part of our baby cafe, as well as Nicole Troop, who's an RN IBCLC, who's kind of rounds out the three musketeers of our baby cafe. One of the main questions is, do we welcome all feeding methods at our baby cafe? 1000%. Yes. We have families that are fully formula feeding, pumping, combination feeding. And because we've had 2 years now, we've had people have their second babies that come to our baby cafe, and we've seen people really explore different feeding choices in partially because they've found non-judgmental support. I've literally had someone say the other day, if without baby cafe, I would have formula fed just like I did with my first, but I knew I would have this weekly. So I figured I might as well go for it, since I would have this, this backup support every week to check in on all the things that come up. So yes, I think it's a great question. And that's actually really important to us, to be inclusive of all feeding methods and all families. And I think the other question was about interfacing with WIC. And I think that that's a really good question, and one that we can do a better job at. I know that our WIC office is aware of our baby cafe. I do think we've had people directly refer, but we also are a small community, and most of the people that are utilizing WIC babies were born in our hospital. And so they've heard about it through us too. But I think because there is, a transportation that's possible, we could branch out and make sure that, people outside of our direct community are aware of it. We do have families that regularly come from Massachusetts and New York, especially since our hospital sees families from all those places. But we've also had families come that haven't given birth at our hospital. And I think we could do better outreach to make sure that those folks knew about the cafe for sure.
Thanks, Kimberly. I'm struck really with this group about thinking about our state and the rurality that we have, and the difference, such a difference between Chittenden County and the immediate surrounding areas and, rural areas. And I think hearing about, the peer counseling program, I'm curious from Brittany and Chantel being, in the northeast part of the state, like what it looks like, maybe even not specifically for substance exposed newborns, but how big is your caseload? I know from talking with Courtney, she mentioned there's only 2 IBCLCs in your whole area versus Chittenden County has quite a few. I'm just curious about if you could share a little bit about that.
I'll go first. So this mom that I had that struggled with substance use, this was actually my first and only case that I've ever had. So it was nice to work alongside Chantel and her to just share everything with me and help me to support this mom best because it was new to me and I still have a lot to learn. My caseload right now is pretty big because we had another peer in our area that got done about 2 weeks ago. So I went from about 40 participants to 70 participants.
So yeah, Brittany has a big caseload right now. We have about 25% of our enrolled pregnant and breastfeeding moms have a peer counselor assigned to them. So our total caseload of pregnant women and breastfeeding moms, of course, in WIC, you're eligible for up to a year postpartum if you're breastfeeding. In Newport, our total caseload with pregnant women, breastfeeding moms, babies, and children is around 900, and it's a little bit less than that in St. Johnsbury. So, as you mentioned, we are supporting a big area. Geographically, it's a large area, especially in Orleans County and northern Essex County. Some of our families are traveling 45 miles to come to either our district office or our hospital. Brittany's support is all by text messaging or phone calls or emails. WIC does some virtual visits also. And our lactation consultant at the hospital does postpartum phone follow-up for a lot of our families. So she does check-ins, and we work really closely as a breastfeeding coalition. I actually provide WIC services in our pediatric medical home here on the hospital campus. So I'm able to meet with newborns, WIC families, do a lot of WIC enrollment, and work really closely with the maternal child health care coordinator here who works at the OB office. We have universal referrals, so everybody who might be eligible for Medicaid is automatically referred to WIC. So we have great partnerships, and I think that's what makes it work in a rural community to make sure that families don't slip through the cracks. That collaborative, comprehensive care, let people opt out of things rather than opting in, if that makes sense, Molly.
That's great. Thank you. Yeah, Rachel.
Hi. My name's Rachel. I work for Easter Seals, providing intensive family-based services to families at risk. So a lot of, pretty much all the families I work with are all somewhere DCF involved. And I'm thinking about the case example that was presented by Brittany and wondered about like the guidance and the protocols, like, you know, she had to be approved first before she could move forward with breastfeeding. What are the guidelines and protocols with that? Like, did she have to, what, in a situation like this, I don't want to put the person on the spot or, you know, this person, point the finger or anything, but is there, like, if there's a concern for substance use, do they have to go through like a UA process to get to the point where like, yeah, you're clear? Or, and I'm also wondering about statistics and how much the body can filter by the time it gets to the breast milk. Like, big questions. I'm sorry for load it all on you, but
That's okay. Courtney, do you want to talk about the protocol part?
My unmute button for some reason on the same screen. They, as far as the screening, we are not automatically doing urine drug screens here. And Adrian Paul, the NICU attending that's been working with us, has been working hard to provide education about that as well, where many years ago, that was a pretty common practice. And for a lot of patients, quite invasive, and a lot of autonomy to communicate any needs they have about their health and substance use. So as far as educating about timing, we've been really trying to utilize that patient handout, the trifold, just because it does give you very clear timelines of when it is safe to provide milk. And I think bringing the conversations about newborn safety has been really helpful. we know parents want the best for their babies, and they're, I think, in that realm are more willing to communicate things that they might not have told years ago. To answer that, I think you had bigger questions. I might have missed something.
I had another question related to, unless there are other burning questions right now.
I had a quick
Yeah,
question
Kimberly.
along the same lines. I was wondering if at any point the consideration about testing the milk came up, because I wondered if we're doing analysis on mom versus the milk. I'm just curious.
We that's not something that's recommended
Okay.
because we know the pharmacokinetics of the substances, and so we can, if someone had cocaine use before delivery, we know after 48 hours it's going to be gone. And just the approach of collaborating in multidisciplinary way, keeping communication lines open has been the most effective. Yeah.
Great.
I do
And
feel
last,
sorry, I do feel like part of my question, maybe I didn't present it clear. Like what is the protocol like? You know that they have there's a history of substance use. Who decides, I guess, to give the guidance to not breastfeed and pump and dump until they're at whatever that point is of not using?
well, it's when they come into the hospital to have the baby. The OB team works with the pediatrics team, and so then we, initiate the guideline and follow through with it and communicate about the timing of use and how long it would take for the substance to clear.
And I'll just add, Rachel, there is not a statewide policy or protocol in place.
Yeah, that's just for
So
our hospital. Yeah.
every single hospital, every single DCF district hospice, every single case is handled differently. I mean, our goal is to spread something that we feel like is the most supportive of breastfeeding, you know, out into the community and hope that other hospitals will adopt a similar approach of really using the science to say, this is really safe for people to have the golden hour. This is how much time you can feel good about saying it's out of the milk. Nobody needs to have repeat UAs, repeat UAs, repeat UAs to show that the substance is gone, because we know how much time it takes to pass. With that said, if someone has contracts with DCF or with DOC or someone, that's outside of what we recommend as medically indicated. So there's a very big difference between testing that's medically indicated and might change our management of the newborn, and things that are set into place by another agency. So I think that's just really important to know that although it'd be great to have a statewide approach, we're not quite there yet. But it can always be helpful for the family to ask their team to really collaborate together to make sure that all of the parts of the case are being considered when anyone gives advice about breastfeeding or providing milk after they've been separated, right? That's another whole topic we didn't talk about today.
Thank you. Any other questions? I just had a brief question just about home health and how that fits into all of this, particularly in a rural area, but I know, rural versus Chittenden County is a little different. And I just wondered if anyone here wants to speak to that.
I can briefly say that WIC nutritionists and our breastfeeding designees do refer parents to home health. They don't all take those referrals, but we certainly work closely with Strong Families Vermont program that have the responsive nurse visits and also the longer extended nurse visits that will follow a parent from pregnancy all the way through the postpartum year. So we do make those referrals.
Great. Well, I want to thank all of the presenters for their great insights and perspectives, and for everybody who attended this webinar. And we're going to close it down now because it's 1 o'clock. but really appreciate you coming and would love for you to fill out our brief little evaluation form so we can just keep making things better. Have a great day, everybody.